Welcome to InCast. Enjoy Health Education's podcast for dedicated healthcare professionals, educators, and administrators who are passionate about making a difference, encouraging healthy outcomes, and finding innovative ways to engage and empower new families and staff. Here's your host, Debbie Young. She's been a childbirth educator and doula for almost 30 years and came to Enjoy based on her love for educating families.
Hi, and welcome. Today, our topic is talking about perinatal mental health, tips for educators and doulas. We're diving into a vital topic that touches the heart of the work that we do as birth professionals, supporting mental health during the perinatal period. Whether you're a childbirth educator, a doula, or another type of birth professional, your role is uniquely positioned to offer meaningful support during one of the most emotionally complex times in a person's life. Perinatal mental health disorders, or PMHDs, affect 1 in 5 individuals during pregnancy and postpartum, yet they often go undiscussed or unnoticed. In this episode, we'll explore how educators, doulas, and other birth professionals can create safe spaces for open conversations and recognize the signs of PMHDs and offer compassionate, informed guidance to students and clients alike. We're recording on May 7th, which happens to be World Maternal Mental Health Awareness Day, and we are honored to welcome 3 outstanding leaders in the field of perinatal mental health. Dr. Celeste St. John Larkin is a Prosper Project Director and lead psychiatrist, as well as an associate professor in psychiatry and OBGYN at the University of Colorado School of Medicine. She holds the Anschutz Chair in Perinatal Mental Health at Children's Hospital Colorado and leads the Colorado Prosper Initiative, supporting providers statewide through expanded access to perinatal mental health and substance use care. She also directs the Healthy Expectations Perinatal Mental Health Program, offering specialized group therapy focused on strengthening the parent-infant bond. Dr. Sarah Nagel-Yang serves as Prosper Education and Training Lead and Associate Professor in the Department of Psychiatry at the University of Colorado School of Medicine, where she is also Vice Chair of Quality. Sarah is the Executive Director of Colorado Women's Behavioral Health and Wellness. She has been a specialist in reproductive psychiatry for over a decade. She's known for developing innovative and accessible models of care. She co-edited the first comprehensive textbook on women's reproductive mental health and leads national efforts in education through her role with North American Society for Psychosocial Obstetrics and Gynecology and the National Curriculum in Reproductive Psychiatry. Dr. Laurel Hicks is a Prosper Evaluation Lead and Research Scientist at Renee Crown Wellness Institute at the University of Colorado Boulder. A licensed clinical social worker, she holds a dual title PhD in social work and infant mental health. Her postdoctoral work at the University of Denver centered on perinatal depression and fetal programming, and she continues to shape research and evaluation that centers early relationships and maternal well-being. Before moving to the mental health field, Laurel was a birth doula for many years. Welcome, ladies. Sarah, can you sort of give us an overview of perinatal mental health disorders? What does that mean and how common are they?
Yeah, sure. So perinatal mental health disorders refers to mental health disorders that are experienced either during pregnancy or most would agree up to 1 year postpartum. So this is a combination of different diagnoses that fall under the scope of perinatal mental health disorders, or PMHDs. I think sometimes people find it surprising that perinatal mental health disorders are the most common complication of childbirth.
I was almost floored when I heard that. I'm like, no, it must be preeclampsia or it must be postpartum hemorrhage. Nope,
Yes.
it's not.
Absolutely. And I think, Debbie, it's so surprising because if we think about how we prepare individuals for childbirth in the postpartum period, how we educate folks around navigating pregnancy, and even how our clinicians are trained and educated. We spend a lot of time on other types of complications, as you mentioned, and by comparison, oftentimes mental health disorders kind of fall to the wayside or remain a secondary topic when actually they affect a lot of individuals. So, the prevalence rates estimate that about 20% of perinatal individuals will experience either a mood or anxiety disorder during and after pregnancy. And then we know there are other conditions that are either more prevalent specifically in the postpartum period or throughout pregnancy as well. And so it's estimated that about 10% of individuals will experience postpartum PTSD, or post-traumatic stress disorder. That is PTSD that is often based in the birth experience itself, but may have foundations on traumatic experience that have happened even before birth. About 5% of individuals will experience postpartum obsessive compulsive disorder, or OCD. And then postpartum psychosis is also part of the perinatal mental health disorder kind of spectrum. Postpartum psychosis affects around 1 to 3 per 1,000 perinatal, or specifically postpartum individuals, and obviously is one of the more severe perinatal mental health conditions, usually considered a psychiatric emergency. I'll also mention that the reason that we use the phrase perinatal, while some of the diagnoses that I mentioned, really have the period of vulnerability in the postpartum period specifically, when we're thinking about the most common perinatal mental health conditions, we're thinking about mood and anxiety disorders. And we know that when we're talking about depression, about a quarter of those who experience postpartum depression, if you do a careful history, they actually entered their pregnancy already with depression, and it just, was unnoticed or untreated or undertreated. About a third of individuals actually experienced the onset of their depression during pregnancy, if you do a careful history, and about 40% of those who experienced postpartum depression, the depression actually began in the postpartum period. So we really think about wanting to identify those conditions as early as possible and being aware that they may be starting even before pregnancy and definitely during pregnancy as well.
So I think my educator and doula friends really need to pay attention to that, because these are things that we can talk about to parents and normalize that you're not alone. There's a lot of people that are understanding and seeking help. So yeah, appreciate that. Are there health disparities around mental health the same way they are around other pieces of women's health, Celeste?
Yeah, it's very prominent and it's been in national news a lot. And I think we're all becoming more aware and trying to address these things, both through how our program operates and was built, and also our education. So in Colorado specifically, Black women are 2.5 times more likely to have a death in the perinatal period or during the postpartum period. That's still most commonly due to medical conditions related, but other folks, such as Native American women, are almost 3 times more likely, and white and Hispanic women are more likely to have the deaths be due to suicide and unintentional overdose. Importantly, also, I learned as we started to do this work that women in very rural counties, the most rural areas of our state, are more than 3.5 times more likely to have a death in the first year postpartum. So when we think about, originally I'm a child psychiatrist by training, and when we think about the impact on babies and families and infants, Having an ACE like that, an adverse childhood experience of losing a parent, is really a big impact. So that's part of our mission, is to try to decrease those numbers and those health disparities.
Yeah.
I wanted to add, one way we built our program to do that was by having community psychologists who are expert from some of those backgrounds of different ethnicities and races and communities, to try to inform how we're addressing these conditions, because there's a lot of stigma and other things that can get in the way.
It intrigues me that you say that rural is a high need area. Much of my adult life, I lived in towns of about 800 to 1,000. And so I can tell you it's lonely. It's lonely when you're living rural. And
Yeah.
Not only is it lonely, but I think people are watching you more closely. It's not like you can get lost in the crowd. And so sometimes there may be shame or not wanting to admit because the neighbors are going to talk about you.
I grew up in a really small town of about 1,000 people too, in Michigan. My parents regularly drive 2 hours to get healthcare. And so I think we know there's a lot of data and statistics out there about maternity care deserts. And I think those are also the same areas where it's hard to get good mental health treatment and substance use treatment. And yeah, people are very stoic. So it's hard to sometimes admit that you need help or find supports.
Yeah. And you might not have that person who can recognize that you need support also, because maybe you don't have those type of people in your community. And so who do you reach out to? So I'm glad you're keeping an eye on that. Laurel, can you talk about how PMHD is diagnosed or identified? What does that look like?
Different people approach this in different ways. Often in a lot of clinics, they're utilizing different screening tools, like the EPDS is one, which is the Edinburgh postpartum depression scale. There's also some others that they use in clinics, the PHQ-9, the GAD-7. These are all just acronyms. The nice thing about the EPDS is that it's accessible. It's only 10 questions. It's been translated into a ton of different languages. And anyone can really fill it out and get a response. And I often suggest to people that I work with that they just fill it out like periodically, just to see how they're doing, whether they feel like they are depressed or maybe just struggling or overwhelmed. They could be stressed or anxious, just to kind of see how things are going. And also, like, that's not the end all be all. Someone could be like, this isn't describing my symptoms, but I'm really not doing that well right now. And I often will even coach some of the clients that I work with to talk ahead of time with their trusted supports, whether it's their family or their friends, even if they have one, to say, if you notice me like not seeming like myself, I give you permission to say something to me. Because often, like, so many people on the outside will be like, I think they're really struggling, but is it my place to say something? And then they really worry about that, or their partner might worry about that. And so I really do encourage just like the pregnant individual to have those conversations ahead of time. Like, you can tell me, I give you permission. And like, please do if you think this is happening. And I think just giving that permission can be really important and meaningful, just in identifying things really early on.
Yeah, I think that's so important. I'm definitely adding it to my childbirth education class. I think a lot of times when without assistance, how does the dad or partner know that this isn't just normal? So people are probably missed because the family or the close associates just feel like, well, this is probably what a postpartum mom should or postpartum person should be doing, right? Without that information that I can supply prenatally, then they might not pick up on it.
Yeah, and to add to that too, the idea of normal, I think, is like an interesting thing to explore, because being a new parent or a pregnant person, at least I can speak to in the US, is really stressful and can be really challenging even under the best of circumstances. And even if somebody is like feeling like, oh, this is just the way that postpartum is, or this is just the way that pregnancy is, I'm feeling like nauseous or low energy, or I'm not sleeping. I still do think that there's a lot of supports that people can receive out there that can just help offer just so much more during that period so that people really do feel supported and they don't feel alone and they can start to feel more like themselves, even when they don't maybe fit a diagnosis of a major depression disorder or something like that. There's so many ways that extra support can just be so beneficial for the entire family so that people can really be thriving instead of like barely surviving.
And I know we said earlier that you were a birth doula in your past life, right? And before you got into this work, did you ever find yourself realizing someone needed help and helping them find help?
Absolutely. And I also was a prenatal yoga teacher too. So I worked a lot with people in these non-medical kinds of ways. And one of the reasons why I ended up getting into this world of like clinical and research work was because I saw so much in the community where people were struggling and they didn't know what to do, and they didn't know who to turn to, and they didn't know what to say. And I think for me, getting more comfortable with having those conversations as a labor doula or as a prenatal yoga teacher or just as a, I don't know, human being living in community, the more that I was comfortable with that, the more I could offer, and people would start to feel comfortable coming to me with some of those questions. I think that that's, at least in my work, it's been a really important way to help bridge things in general for people to receiving the care that they're really needing, whether it's like from a psychiatrist or from a therapist or from even just finding doulas or peer support or groups or things like that. And that's one strength that I see in the perinatal community is that there's so many people out there with that knowledge that they're just waiting for someone to ask them so that they can be like, yes, I can help you. Like, let me help support you and find these trusted people in the community.
Mm-hmm, mm-hmm. And I know we're going to be putting some websites and so forth in the notes for people to pick up when they're listening to this. And so if there's any websites that are valuable to the parent, but also maybe giving the provider, the doula, the educator, the yoga instructor, some additional information, we'll try to put some there because I think this is a big topic. Well, Celeste, what do you think are barriers to accessing treatment? Why are people reluctant to access treatment?
Yes, I think it comes a lot back to awareness and knowledge, and that it is a confusing time. Nobody's sleeping well during that first year postpartum. So is it really that you're just not able to sleep because you have to wake up with the baby for feeding and things, or you really can't sleep because you're anxious and ruminating and thinking about scary things or having intrusive thoughts? And I think that ties to one thing besides just not understanding that there can be these conditions in the postpartum period, because often it's culturally this wonderful time and you see things on social media and in movies and things like this is great. But we know it's really hard in real life. But also stigma about just having this condition, and you must be a bad mom or a bad parent, or what did you do wrong to be feeling this way, instead of just being blissfully in love with your baby. And then also women and families really do worry, if I say something about I'm depressed, not happy, or I'm having trouble coping or even taking care of myself, people are going to think I can't take care of my baby and worry that the baby might be taken away or taken by, social services called or things like that. So I think that is a real factor. And we want to reassure people that getting help or asking for help is not a sign of weakness or a sign that you're a bad parent, but actually a good parent, because taking care of yourself is good for the baby too.
I actually did have recently a postpartum client who I was working with virtually. And when we got down to the point where I said, it's okay to reach out in your community for help, and I can help you find people to talk to, she said, yeah, but CPS is going to come and take away my children then, right? Because she said she heard it in social media that you shouldn't say so because you're going to get your children taken away. So I convinced her that no, that wasn't going to happen, and she did seek help. But is social media a good thing on this topic, or is it a bad thing, or kind of a toss-up? You get both.
I suspect it's a toss-up, but the things that people find first on social media or in the news coverage are the bad things, right? And it can lead to, I guess people only post the really good things or only the really bad things, so that it's an unrealistic view. So you see stories in the news of really, sad things happening, like death by suicide or harm to infants. And that is scary, but not everyone who has a postpartum mental illness is going to have that happen. And what we're trying to do is prevent things from getting to that point where there are scary thoughts or actions. And then otherwise you see only the good, happy, smiling pictures and think that that must be how everyone feels all the time. And if you're not feeling happy, or you're feeling so anxious, you don't want to go out of the house and do things with the baby socially, that can leave you feeling even more isolated or more like, what's wrong with me? So I think it's a double-edged sword. And I guess maybe the positives, and I don't know if Laurel wants to chime in, because I feel like you're on some good supportive groups of both people who treat mental health conditions and otherwise, but there can be really good connections that people make with meetup groups and finding supportive environments for people who do have mental health conditions. That can also be a good thing and decrease isolation.
So, Laurel, can you talk about how we can help people find trusted sources?
Yeah, absolutely. Because I mean, that is a reality that still exists, especially, we know that there's a lot of like structural racism in women's healthcare in general and healthcare, and there's been a history of that. So I think that there's a lot of communities that are extremely skeptical, and for good reason. Like they haven't always been treated well. And there are a lot of communities, like a lot of providers and communities of birthing professionals out there that are really trying to disrupt that. And so I think that part of it is, and for the doulas and the professionals on the call, like hopefully they're already doing this, but there are ways to really connect with the people that are like either within the community, whether it's a virtual community or in person, to start to build relationships there so that it can be like, hey, I know this person, right? Like I can send you to this person or to this clinic or to this ER or whatever. And I know some people there. I know that they have this baseline kind of knowledge. I know that they're really, really looking to help people, and that their automatic is not going to be thinking that you're a terrible parent and calling, calling the CPS, Child Protective Services, or calling, or even like, I don't know, treating them poorly, and treating them with harm. So I think that building those relationships in the community is really key. And each community likely knows the people that they can go and trust. If you get like just even a little dip your toe into it, you'll start to find that. So I really encourage people to build that and to build those trusted relationships too, not just with the community agencies, but also with the hospitals and the providers and the obstetricians and psychiatrists, because often their skills are really, really needed as well.
And maybe as a doula, an educator, a lactation support person, a yoga teacher, having a list of the local providers that can help is probably a good thing. So
Absolutely. And I always recommend too, like for myself, I know if I'm giving a referral, like say it's for a massage therapist or something, I'm often like receiving a massage therapy session from them. Like I'm trying to like understand actually what that is if I can. I can't always, but doing my best to understand, like, does this seem like a skilled and safe person to send these people to?
it would be terrible if you sent them to somebody that wasn't good. But I also say, if you don't click with that whatever kind of provider, don't stop there. Explore another provider that fits your point of view.
Yeah, that's a really important piece to add, I think. Like, Not everyone is a good fit right away.
Sure.
But there's more people out there doing this work. There's an abundance of them.
So, what evidence-based treatments are available for women when they're out there looking for something, or for the birth professionals to have on their referral list? What can we look for?
Yeah, well, of course, medication is something that people often think about, and medication can be extremely helpful for folks that are experiencing more like moderate to severe depression, for example. Often a combination of both medication as well as some evidence-based therapy treatment is really helpful as well. Um, some of the main modalities that I guide people towards are interpersonal therapy, also called IPT. Of course, cognitive behavioral therapy is a really common one, CBT. Um, there's some of my work is focused on mindfulness-based therapies, specifically mindfulness-based cognitive therapy. And there's a lot of evidence out there and more building for that. Behavioral activation is another one. And then there's also things like, honestly, like figuring out how to sleep, like doing some interventions around sleep can be extremely important. Um, Things like yoga, there's evidence around that, exercise. And there's also evidence, and one of the research projects I work on actually is around like postpartum doulas and mental health, Debbie. So maybe we can talk another time about that. But there's some evidence around even just receiving postpartum doula care can help to reduce symptoms of depression and anxiety. And another program that I work on at University of Colorado is called ALMA, which is a peer support program where peers with lived experience deliver something called behavioral activation. And we also have evidence that that reduces depression and anxiety. And so there's a lot out there. And I'll say like that can be a lot to figure out like who even does all these things. There's a great resource that Postpartum Support International put out called the PSI Directory. And so it's a huge directory of providers. It's psidirectory.com. And everyone at least has some base level experience in perinatal mental health and training in that. And you can search by all of these different modalities to try and find like who takes your insurance and what modalities do they offer and where are they located and all of that. So that's a great way, even just having that as like the one thing to refer people to can be really helpful.
Would there be, like we were talking about rural families before, would there be telehealth people on there, or
Yeah,
some sort
100%.
of,
There, you can
yeah,
sort by telehealth on there.
okay.
And, you know, um, in the last like 5 years, there's been a huge expansion of telehealth availability. So most providers are offering telehealth now. So even if they are rural in the US anyways, and in Canada, I'm originally from Canada, so I know a little bit about that country as well, but also in Canada, there's a lot of offerings that are virtual too.
Okay.
Mhm.
COVID helped us in some aspects, right?
Yeah, it did.
And I know that sometimes, because I train doulas, both birth and postpartum doulas, and I hang around nurses and other educators. And I think for a long time, there's been difficulty or hesitancy, or maybe feeling like mental health is a taboo subject and we're not qualified. We shouldn't be talking about this, but I think that's wrong. What do you think?
I agree. I mean, I think that mental health it would be really rare to find an individual that had never had moments in their life where they didn't experience some kind of mental health challenge. It's really, or at least a loved one did. And so it's something that I think everybody is touched by in some way. And having nurses or doulas or any of that just even just initiating that conversation also I think starts to destigmatize it as well. So then it becomes something as common as, I don't know, some of the other things like how far apart have your contractions been when like someone comes in, right? Like something so common that people say. And that also just helps to destigmatize it across the board.
I think I'm saying something wrong. So sometimes when I see somebody that has hired me to be their postpartum doula acting in a way that in my own mind, I'm like, we need to help this woman get a referral.
Mhm.
I might say something like, this is not what I usually see. Can we talk about this? Is
Mhm.
that, would that make her feel uncomfortable? Because am I comparing her to other people?
Mm. It's an interesting question. I think sometimes I end up, even in like when I was a doula, I would end up in their like prenatal appointments or things like that, just asking them, and as a therapist, I do this too, asking them like, what are your thoughts around mental health and depression? Like, what did you learn growing up around that? Um, do people in your family like, are they open about talking about any of that? Or is it something that feels like even that word depression doesn't fit for you? And so I'll almost like start the conversation that way just to get a bit of a baseline. And then if I am seeing some symptoms later, then I might say something like, I feel like, I feel like you maybe could be experiencing some depression. Like, what do you think?
Yeah.
There's
Yeah.
this questionnaire. We can fill it out together just to like learn what these symptoms are, because some people don't even know. And that way it's like, oh, this is actually showing that you're scoring kind of like in the higher amount of this. Like, do you think you need some extra support? Like, would that help you feel better? Do you think it could help you feel better? And so I think I open up it more of like a dialogue. Um,
Thank you.
yeah, that's how I tend to approach it. I don't know if others have like ideas of how to approach that conversation, but
I think I could actually direct them to the website or hand out the Edinburgh scale and just say, keep this handy. You know, this is something that people should be doing on a regular basis. Common, everybody's doing it type thing. It's like getting Nikes, right? So everybody's doing it.
And Debbie, I hope it's okay. I want to just jump in and say I totally agree with what, with Laurel's kind of point, and to highlight one of the things that she said, which was, that even just asking the question helps to destigmatize things. I think that asking questions just out of, sort of with an openness and a little bit more of a curiosity really has a powerful impact, both on destigmatizing and also just signaling to the person that I'm a safe place for you to talk about this with if you need that. And sometimes, they don't need that in that moment, right? Or they're not ready to take you up on it. But that will stay with them, and they will know that about you going forward. And it opens a door even later if they get more concerned about how they're feeling.
Thanks for that thought, Sarah. That was helpful. Sarah, can you talk to us a little bit about medical management? I know Laurel was talking about groups and different styles of management, but medicine sometimes plays a part, right?
Yeah, absolutely. And, I think of, as we think about these different tools, I know Laurel kind of went through a few different evidence-based psychotherapy options and other types of evidence-based kind of supports. I think of medication as another tool in the toolbox, right? And something that we can have, and kind of sometimes in the back of our minds in case it's needed. And, one of the ways that I think about, is this the time to start to think about medication, is the severity of what's happening, right? So if I'm seeing that somebody their symptoms are so severe that it's hard for them to sort of have the level of function that they are expecting themselves to have or wanting to have. If it's something where they're feeling really hopeless, I think that's a really big indicator of severity. And certainly if they're having any kind of thoughts about harming themselves or feeling like life isn't worth living, the severity alone is enough to indicate that this might be somebody who really would be helped by medication as part of their overall plan. Beyond severity, sometimes it's more about like how persistent are these symptoms, right? It's very normal for all of us to experience ups and downs with our emotions. And sometimes even, days where we feel like we're just not, we're not ourselves today, or this is not a good day or an off day. But when that day becomes most days of the week, or most weeks of the month, and it's not getting better, that's a sign that we might need to think about medication. And then finally, sometimes we start with other types of therapies, like the psychotherapies that Laurel mentioned. But sometimes people come to us to ask about medication because they're noticing that some of the tools that either have been helpful for them in the past or either expecting to be helpful now, aren't feeling like they're sticking, they're not getting better. That's another indication where sometimes people start to think about medication as another option.
Okay. And a lot of moms that I work with intend to breastfeed. And I think that's a big concern where they might not reach out to seek help because they think if I get on medicine, then I have to stop breastfeeding. But that's not true, right?
Absolutely. Yes, that's a total misconception. Actually, most of the medications that we utilize for mood disorders, for anxiety disorders, even for some of the other conditions I mentioned, like obsessive compulsive disorder, the most common medications that have the most evidence for use in those conditions actually are considered compatible with breastfeeding. When we think about when we use medications during breastfeeding, we think about a couple different factors. One is what is the rate of transmission into the breast milk? So that's called the relative infant dose. Medications are generally considered compatible with breastfeeding if the relative infant dose is 10% or less. Most of the medications that we use for mental health conditions are well below that 10%. And then we also think about what do we know? How much do we know about the safety of this medication in breastfeeding? And it so happens that the most common mental health medications, such as selective serotonin reuptake inhibitors or SSRIs, are some of the most commonly used medications in general. And when a medication is used commonly, we know more about it. And so, there are plenty of medications that are compatible with breastfeeding, and more and more obstetricians and family doctors and psychiatrists are familiar with that data. And as we'll talk about as we move forward in the conversation, there are definitely tools for clinicians, prescribing clinicians, if they haven't had training in that area, tools for them to get the information they need to safely prescribe in breastfeeding.
Can I jump in and add about pharmacists? We're going to talk about our program in a little bit, but we've had some call, and one of my goals is to help pharmacists also know what is safe for breastfeeding or pregnancy or not, because sometimes the reproductive or perinatal psychiatrists were immersed in this all the time, and we wouldn't prescribe something that's not considered compatible or relatively safe. And sometimes the pharmacists don't know that, or don't know where our recommendations are coming from, and may actually try to give the patient different information. So I think we always encourage people to coordination of care is ideal, so the doctors can talk to the pharmacist, or the prescriber of whatever kind could talk to them if there's a concern. And not just putting it on the patient to feel like they're getting two different information, different conflicting information. Yeah.
So
we're hoping to take calls from pharmacists on our line, was my point as well.
Celeste, talk to me about mental health access programs like Prosper. What does Prosper stand for, first of all? Why are you out there? I'm loving looking at your website. Let me know.
Yeah, great. Prosper stands for Perinatal Resource Supporting Obstetric Screening, Psychiatric Education, and Referral. So we're a program modeled after the original one was in Massachusetts called MCPAP for Moms, also grew out of a child psychiatry access program. So the idea of these programs to improve access for healthcare providers to get kind of well-educated and appropriate consultation with a psychiatrist started about more than 20 years ago. So it's a good kind of evidence-based model in that it saves a lot of money and increases access. And the reason I say it saves money is that there are fact sheets and data out there that share about the cost to society or to work and things in general for one mom baby pair. That's if there is impairment and because of depression or anxiety, it's about $32,000. And these programs can help the frontline healthcare providers address that in a much more cost-effective way. So one of the key points about the Access program is that we are here to support and provide education for those frontline healthcare providers, so OBs, midwives, family practice, pediatricians, and most states like ours also provide access for doulas or nurse home visitors or anyone who really interacts with women or individuals in that pregnancy and perinatal period.
Probably including lactation, right?
Yes, lactation consultants too. Yeah. And as we talked about pharmacists a little bit earlier, we'll take calls from anyone. Also, sort of a interesting thing that's a little different than the child programs is that most psychiatrists in adult training don't necessarily get training in reproductive psychiatry, like pregnancy and menopause and things like that, which is kind of shocking given that we're half the population of women. But unless you happen to seek out an elective or happen to have a person who gets pregnant while you're seeing them, you may not get official training or be as specialized in it. So we often get calls from psychiatrists and psychiatric nurse practitioners or PAs about questions too.
You're very specialized with all the right information. I appreciate that.
Yes, we try. So our 3 goals are to have a sort of same day, often with callback within 30 minutes or an hour for a healthcare provider that calls us if they're seeing someone in their office or they know they're going to be seeing a patient and know they're going to have questions, they can call us ahead of time. We have a wonderful resource and referral coordinator who answers the phone or takes the messages and then passes on the call to one of the psychiatrists on our team. We're available weekdays 9 to 5, so it's not an emergency or crisis services, but we are happy to discuss those situations as appropriate, but we have emergency resources on our website. Also, it's not for families or patients to call. There's really good other resources for that. And one of them is the Maternal Mental Health Hotline. That's a federal, the Maternal Mental Health Hotline, which is a national program that is available 24/7, sort of like a crisis line, but it specifically has often people with lived experience, other moms on the phone, or social workers, psychologists who answer those calls and can help support both in a crisis or just someone needing to call and wondering, do I have depression or something?
Yeah, that's great.
Yeah. And then the other piece that our program does, besides just phone consultation about diagnosis or medication management, is providing education. So we've done an ECHO series. We hope to develop some more online videos and educational modules, sort of like you're doing for childbirth educators, but we have focus on people who are prescribing medications or doing screening in their practices. And then we also, with that resource and referral specialist, work on getting community connections and appropriate referrals that are trauma informed or, appropriate language and cultural congruency, which we talked about can be important in addressing those health disparities. So that's those 3 arms of our mission.
Those are great. And I'm really glad to hear that you have that community doula, peer, educator support too. And I think that it's surprising to me a little bit. I didn't know that. And I think that our listeners are going to be really excited about that. And is this something that's Massachusetts and Colorado based, or is Prosper in other states? How would somebody find a program like yours in their state?
Yeah, we will definitely share a link to the national network of perinatal psychiatry access programs in your material. Over half the states now have a perinatal program, so we are specific to Colorado and obviously Massachusetts, and there's more than half of the other states either have funding through federal grants or through state money to build similar programs. They're each a little different and tailored to the needs of those communities or states. There is also a national line, and we talked about Postpartum Support International in other ways, but they do have a phone line that's staffed by volunteer psychiatrists that is available nationwide. And also the VA has a really great reproductive mental health consultation line that they access electronically for providers who are working at the VA. So there's a couple national things, and there's one program that started in Canada, in Ottawa recently. So it's growing.
Well, wonderful. Well, we're getting toward the end of our discussion, but I wanted to follow up with moms who maybe didn't identify that they needed help before their 6-week postpartum visit with their OB, but um, they may say, oh, it's probably too late to do anything anyway. And she may not see a provider again for a while. I know OBs are getting better at saying, follow up with your personal provider, but I don't think that often happens. I think I've seen the statistics on it and it's not good. How can we help moms get continuing care if they didn't identify that they need help to begin with?
Yeah, I think the medical providers or clinics that parents do often see throughout the first year is at their pediatrician's office or their family practice physician or provider for their baby. And I think there are guidelines that recommend the EPDS or other screening for depression and anxiety at the well visits, up to 6 months. And I think ideally through the first year would be great. So I think knowing that even though some moms don't want to share if they're struggling with their baby's provider, like we talked about, it's really good for the baby to take care of yourself. So that is usually a very safe place to talk about it. And a lot of clinics have integrated behavioral health therapists that could come in and talk, or that you can get the screening and then get some additional resources. Encourage the pediatric provider to call lines like Prosper and ask for resources, even if they're not the prescribing doctor. So I think that's one option. And yeah, talking to other moms or online support, like we talked about, is important, or calling that maternal mental health hotline that is out there nationwide is a good way to get started.
And I'm just going to share this. In my class, when I'm talking about mental health, I say, if I take off my glasses, I can see you all, but you're kind of fuzzy. And I might be able to drive home safely without my glasses on, but I'm running a risk there. But I chose to go and get a prescription for my glasses so that when I put them on, I can see well. My world becomes clearer with this assistance I've chosen, and choosing to get help for your body, your eyes, and your mental health. They're all the same. It works the same way. You can survive feeling bad. You can survive being anxious. You can survive having depression. But when you put your glasses on, so to speak, when you get assistance, possibly medication or other therapies, you're going to change the way you look at life. So that's kind of how I leave it with my education class.
I love that analogy. And I heard it similarly from another person with lived experience who was talking about Asian American mental health in America. And that was a great example. So I love that glasses analogy. I used to usually say it's like hypertension or diabetes. You can try to lose weight in some cases, or you can do other things to manage, but you can't always. And you sometimes do need a medication for those things. And it's similar. You sometimes need a medication for your brain health disorder. So I think that that's
Right.
a similar example.
I'm dying to say, Debbie, that I also love that analogy. I mentioned to you before, I'm gonna start using it myself. And I would maybe add another layer, which is, when you are seeing, if I wear contact lenses, so I'll say from my perspective, if I were to come to work without my contact lenses, I also just would feel a little fuzzy in terms of like my ability, to be present with people. And one of the things I think is really important about getting help and support and all of these resources that we've been talking about is that it allows moms to be their full self, which everybody benefits from. And that's just, that's part of why I love what I do.
That's great. I love that.
Right. I think the other approach that we try to take both in our program and our clinical settings and lots of places across the country is thinking about that baby. So even if the depression might resolve on its own in, say, a year, that's a long time in the life of an infant. And we're really wanting to help. There are programs and groups and things that can really focus on that mom-baby relationship, which sometimes gets disrupted when there's a birth trauma or even just depression, not talking and the engaging as much with the baby can be really hard. Or if you're so anxious, maybe, there's too much hovering over the baby. And so I think, we're trying to address that too. And that's one of the important things about getting treatment for the mom or the dad, is that we can help those connections and help foster that, even if there's not that great relationship right away, it can develop over time. And that's one of the things that can get better with treatment too.
That's a very good point. Thank you. Laurel, any last thoughts?
I also could talk about this subject for hours and hours and hours. I guess the thing that I would add that we didn't really touch on is that, you know, challenges and struggles in the perinatal period also can affect like the partner too. So putting it out there that it's also really important for partners to find ways to receive support, and that all of this, like, it's nobody's fault either. It's like nobody's fault that someone might be struggling. And sometimes it's like, all of these like contextual factors that happen, like someone has to go back to work super early and they don't have a lot of support, or they're financially struggling, or someone loses a job, or they have other like medical concerns going on, or, there's so many contextual things that go on in this period of time that we often can't control, and it's nobody's fault. And there's so many supports out there and so many people willing to help, that my hope is that people will just, find their way to one of those folks and trust that they'll help them.
Thanks for being with us again. Really appreciate all your thought and wisdom and the passion you have for pregnant and birthing and postpartum families. Thank you for that.
Thank you so much for having us.
Yes, we appreciate it. Thank you.
This episode of InCast is complete. Tune in regularly to hear more insightful conversations. And be sure to visit enjoyhealtheducation.com to see how Enjoy can help you inspire families and staff through our diverse childbirth and parenting teaching solutions. Or call us at 1-800-326-2082. The views and opinions expressed in this podcast are those of the guests and do not necessarily reflect the official position of Enjoy or its employees. This podcast is intended for informational and educational purposes only and does not serve as medical advice, a basis for diagnosis, or recommendation of treatment.